distorted by congenital malformations, fibroids, polyps, precancerous and cancerous masses. Sonohysterography is one method to evaluate the uterine cavity. It is particularly helpful in the context of infertility or abnormal bleeding. During a vaginal ultrasound scan, sterile saline is injected into the uterine cavity, distending it. Because water transmits sound so well, intracavitary masses are easy to identify and the uterine lining can be easily evaluated. Sonohysterography is best done after menstruation and before ovulation. It can, however, be done at any time if you are certain she is not pregnant. It ordinarily would not be performed in the presence of active pelvic infection or active bleeding. Start with a bimanual pelvic exam to determine uterine size, orientation, and pre-existing conditions. Some physicians place topical or injectable anesthetic and use a tenaculum to stabilize the cervix, and then a sound to define the path for the catheter. After passing the catheter, saline is injected a little at a time while transvaginal scanning continues. Begin your evaluation with the lining. Each hemilining should be smooth, even, and consistent in thickness and texture. The lining is expected to be thin early in the proliferative phase among birth control pill users and among menopausal women. After ovulation, the endometrium is thick and becomes progressively sonolucent. Unexpected thickening may indicate the presence of endometrial hyperplasia. When sonohysterography is performed to evaluate abnormal bleeding, a thin lining, less than 3 millimeters on each side, is reassuring that hyperplasia is not present. If each hemilining is 3 millimeters or greater, then endometrial biopsy will be needed to reach a precise diagnosis. While the use of sonohysterography may reduce the need for endometrial biopsy, it does not eliminate it. This 42-year-old patient with menorrhagia had a combined endometrial thickness of more than a centimeter. She had noted heavier menstrual flows with clots for several years, currently lasting 6 to 7 days. These periods were accompanied by moderate to severe menstrual cramps, only partially controlled with nonsteroidal anti-inflammatory agents. During sonohysterography, we found the uterine lining itself was thin, consistent with the birth control pills that she was using to try and control her dysmenorrhea and menorrhagia. The presumed thickening seen on simple transvaginal ultrasound was actually a large endometrial polyp with cystic collections seen within it. We were able to identify the attachment point on the posterior wall of the uterus. This simple explanation for her menorrhagia and dysmenorrhea was easily fixed with an outpatient hysteroscopic removal of the polyp. Following surgery, her periods were light and lasted 3 days. Polyps may come in different sizes, location, texture, and numbers. At times, it may be difficult to distinguish them from pedunculated submucous fibroids. That distinction is not usually important since they are both benign and the treatment is the same. This sonohysterogram was performed using a straight pediatric feeding cannula and 10 cc's of sterile saline. The fluid leaks out through the cervix and fallopian tubes, but the leak is slow enough to allow good visualization of the cavity. One way to decrease the leak is to use a balloon tip catheter. After inserting the catheter, the balloon tip is inflated before the saline is injected. The inflated balloon blocks the leakage of saline through the cervix. The best seal occurs when the balloon is inflated within the cervical canal. However, this may cause cramping pain. A very good seal and less painful is achieved by inflating the balloon inside the uterine cavity and then gently pulling back to seat the balloon in the lower uterine segment. After insertion, the plastic stiffener needs to be removed before the saline can be injected.